Okay, we've been sent another case. It looks like this is for site number 19 for an implant plan. Um, so let's take a closer look. The first thing I ask myself is what type of guide can we fabricate here? And based on the fact that we have CAD/CAM data, I'm confident that we can fabricate an Opti guide here. We can always double check to make sure that our CAD/CAM data is integrated. And to do that, I'll come here to the axial view and I will start going down until say I see the tops of the teeth. And what we can see here is this data is highly integrated around those natural teeth there. So it looks very good. And the good news is, again, to fabricate an OptiGuide, we need at least half to three-quarters of the arch. In this case, we have all the way back to the second molar, perfect situation. And another point I would like to bring up here in this particular one that's very well done is we can see that we have some tissue extension. And the reason I like that is I will often ask CCAT to go ahead and make part of the guide do a little tissue extension there. So we're not solely relying on here, but we can also have a little bit of a tissue stop there uh, for our surgical guide to rest on the tissue. That does help with stability and making things a little bit easier working there. So as I showed in one of my quick tips earlier, we're going to use the CAD/CAM tab to place the implant. So we'll go to the CAD/CAM tab, highlight the restoration, tooth number 19, see how it's highlighted here. Go to the button that has the crown with the implant on it. Click the insert implant. Notice that it'll bring in that this was designed as tooth number 19 in the CEREC. And then we'll go ahead and plan for our ideal size implant, which here is going to be the 5 by 11.5 implants. And again, these implants are totally rotatable and manipulated, and so that you can share with your patient exactly what a dental implant is. And now this will drop the implant down the long axis of your designed restoration. We'll go to our implant align view and we will plan everything. Now, we have a relatively thin site here. Why did I not go with a more narrow diameter implant? Again, my belief is we start with ideal and then we make changes from there. So in fact, looking at this plan, it's pretty close to being ideal. Um, it's not quite centered in the tooth. Here you can see that we're more mesial than we have more space to the distal. So we'll simply move this implant over, and now we can see that we're centered. We can see our occlusal plane looks pretty darn good right here. Probably just a little bit more like so. Move it over, but now, and we can see our occlusal table looks good, our occlusal plane looks good, everything looks good there, but we have a few issues obviously with this plan as it is right now. One, we're hitting this root, okay. Two, we have to take a look at our nerve in this particular case. The good news is our nerve is way down here, so this is where I would make a guess that our nerve is right here, comes up here to the foramen, and then there may be a little bit of a anterior loop right here. So that's where I would say our nerve is, so we have plenty of distance there. In fact, if we wanted to, we could possibly even choose to go a little bit longer. Not necessary in this particular case. The bigger issue that's going to come into play here in terms of not being able to recover from that, and that is going to be how close we are to this adjacent tooth here. And here you can see that with this ideal placement occlusally and restoratively, we're running into this adjacent tooth. So to accommodate for that, we will either have to move over like this, which brings in a cantilever issue, or we will have to tilt our implant like so. And that would probably make the most sense in this particular case, is to go ahead and tilt the implant, gain your distance away from your vital structure, which is your adjacent tooth in this particular case, and then recheck to see how we are in terms of being centered in that tooth. And there we go. That looks a little bit better right there. So we've gotten the distance, we've gotten away from the nerve. And now the next issue that we have to deal with is the buccal plate. So we can see here, this is the outline of the tissue. We simply are not in the bone. Number one, we're not even centered on the tooth, but I'm not convinced that this design is not centered here. The central groove probably should be about right here in the design. So we can probably cheat a little bit this way, but that's still not going to get us the bone that we need here to the buccal of this particular implant. So what are our choices? One choice is we can go with a thinner implant, a narrow diameter implant, but I'm certainly not advocating or comfortable with a 3.5 in the site of a molar. A 4.3 certainly is acceptable in the molar site, and here we can see that it still leaves us pretty thin right here on the buccal. So my guess in this particular case is that this case will need a little bit of augmentation. So in my opinion, this augmentation can be done at the time of placement. Simply do a flap, drill your osteotomy. When you do your flap, come here from the lingual side of the crest, bring it over, go ahead and reflect, try to do a nice clean dissection, and then go ahead and do your osteotomy, place your implant, allow your implant to push, this particular implant will push out the bone hopefully, and then you will be able to simply pack some bone. You can do a little periosteal release here to make sure that you can gain your primary closure back again, place a collagen membrane, and then go ahead and close everything up. This would be a case that I would be comfortable personally doing a 4.3 diameter implant on, doing a little bit of buccal bone grafting here at the time of placement. Hopefully this helps, and thank you for submitting your case.